All right, guys, you guys ready to roll? We're gonna rock this out because I am already screwing over everybody's time, so I apologize in advance. And here we go. All right.
All right.
Welcome back, everybody, to the Mid-Level Show. This is my favorite show on performance medicine audio. For those who are first-time listeners, this is where we get the mid-levels of performance medicine together and we discuss last week's Doctor's Note and Dictations podcast. If you have not listened to the Dictations podcast from Dr. Rogers, you should. Those are his latest thoughts on health and wellness topics. And this past week's topic was a really interesting one, and one that was kind of a piggyback off of last week's topic, which was back pain. Guys, this week we're talking about chronic pain, and the way Dr. Rogers describes chronic pain is pain that lasts weeks, months, or years. And, one of the things he says is that over the course of our lives, 20% of Americans will experience some sort of chronic pain. And I just want to, I'll start off with Fran here. Fran, I know I'm starting with you. What's your thoughts on this past week's Doctor's Note, and have you had any experience with chronic pain?
Thankfully, no.
That's awesome.
But I will do everything to stay out of chronic pain. My thoughts are, I do have a form of chronic pain, and he mentioned the migraine headaches. I've had headaches since I was a child. And when you have a type of pain, you will do almost anything to get out of it. So, I thought his message was really good about how we don't want people on opioids all the time. It's really for acute pain, but if you have some sort of chronic pain, it's telling you something is wrong, and let's try to get to the bottom of what that is. Now, of course, something is wrong with me that I get migraine headaches, but never been able to figure it out. But I keep searching. But I will say that we have a new drug in the office that we've been using that has been a miracle for me. I'm not even scared of a migraine headache anymore because I know within 40 minutes after taking that pill, I'm going to feel great, and it lasts for 2 days.
Well, what is that, Fran? I know that I've heard you guys talk about it before, but why don't you tell us what?
Am I allowed to mention drugs on this? Is that fine?
Absolutely.
Okay, it's Nurtec.
Okay, and you've been using that for your migraines?
Yes.
And
yes, it just became available, I believe, this February.
Oh, wow. Okay, guys, have you heard of that? Has that been something that you guys are prescribing? Andy,
yeah.
Andy, I see you nodding your head.
Yeah. Kara's pulling it out.
Yeah.
There it is. So, Kara, are you taking that as well?
No, I have not taken it. I do have migraines occasionally, but this is great. As Fran already said, you take one, it dissolves in your mouth, and you get relief within 40 minutes, and it's supposed to last for 2 days. Other medications you have to redose if you don't get relief, and also very little side effects, like, fatigue and stuff like that. So I've not used it myself, so I'm glad to hear some positive feedback.
Are you taking any? Are you dealing with any sort of chronic pain in the past or currently, Kara?
No, thank goodness. No, thank goodness.
Yeah, it does seem, it's all about prevention, and doing the best you can with it if you do suffer from chronic pain. Andy, why don't you go ahead and tell us a little bit about your experience as a provider with chronic pain and what your thoughts are from this past week's Doctor's Note?
I loved it. So I don't have a ton of experience treating chronic pain. And two, even with what I was saying yesterday, and Fran and I got to talk about it this morning about the opioid epidemic, how it's kind of pushed in school. Hey, people are pain seekers because opioids aren't curing pain. It's just making you not feel it. So I think, Fran, you brought up a good point of what's causing the pain, and let's get to the root cause. And we talked this morning about something that I think we do well at Performance is we try to dig and find out what these root causes are. So we're not just masking pain with an opioid. That's just making you feel good. It's not curing or fixing the etsology. I do think it's important for listeners to know and providers to know too. Pain is subjective. It's not an objective finding. It's an objective finding. When I rotated in the ER, I loved my ER rotation. I think my preceptor actually listens to our show. Christina, if you're listening, it was my favorite rotation. I loved it.
What's up, Christine?
Christina.
Christina.
So whenever we're feeling for the back, oh, I've got back pain, and you're kind of talking to them and palpating along the spine, and they're going to jump when it hurts. And, or even like when you knock the bed, and that's just kind of a trick to see. That's an objective finding. Oh, I felt tenderness to palpation along a certain spot. But pain, I think it's important to know from my perspective, what I'm learning is empathy towards it. If someone says they're in pain, believe them, they're in pain. But that's why we have those scales of 0 to 10 is what is this pain to you, with 0 being nothing, 10 being you're on fire. But it's really, I think people have, and 2, I have a lot of empathy for the fibromyalgia patients. It's hard to explain and hard to actually have a clinical finding of it. With testosterone, it's low. We see it's low. You got symptoms. You give them testosterone, it comes back up, symptom relief. It's harder for pain. So I'm just learning to have a lot more empathy.
And one thing I'll say about that, one thing that Dr. Rogers has always, I know he coaches you guys on, and he talks a lot about in his notes is always have a solution. Like it's important that when a patient comes in and sees you, whether you have something that's going on that you can't figure out, they need some sort of answer in terms of doing something. I think there was an example with Andy, our mom. She went to a dentist and he didn't quite know what was going on, but he gave her something to do, and that alone helped out a lot. But Amber, I want to hear some of your thoughts coming from with your background in pain. What sort of chronic pain did you see, or have you seen in the past, and what's your thoughts on it?
Well, what Andy was saying about the subjective nature of pain. So when I was in pain management, obviously I did a lot of conferences because I was in a primarily prescribing, I want to say primarily, but opioids were a part of my everyday because of the chronic nature of the pain, mostly failed back surgeries, neck surgeries. Some were non-surgical patients who just had severe stenosis and things that were non-operable. But the nature of pain, it became, and I can't exactly remember the decade, but I want to say it was like the 80s or 90s, the 5th vital sign. Before that, you had patients who were suffering from pain because it was never assessed. It was kind of like pain is a part of life. It's a part of your hospital experience. And then it kind of became, we need to address patients' pains, and it became the 5th vital sign next to, your blood pressure and your pulse and your temperature and respirations. And then they added pain. And so now it's like, yes, I'm in pain. Oh, well, we must get the pain down. And so as a society, we began to over medicate pain because the goal is 0. The pain goal is 0. And from my take, and I definitely think there's a place for pain medications. I definitely, empathy is very important. I think one of the things, especially with patients, chronic pain patients, having that empathy for them, even when you become very jaded, is important. But also, one of my takeaways from Dr. Rogers about the modalities to help pain was the psychological component that is involved with pain. And if you can address that, I had good success. The hard part with cognitive behavioral therapy, it's not covered by insurance, so it can be kind of pricey. But when you take that aspect with pain, I am not by any stretch saying you can think yourself out of pain or you can think your situation better. But there is a psychological component to your pain. And the patients that I had, the ones that were consumed by it and dwelled on it and just never wanted to do anything except get their pain medicine and sit in their house, they fared worse than those patients who somehow accepted and dealt with and tried to manage their life with their pain as far as managing their pain. If that makes any sense.
Yeah, and that's really interesting, Amber, and I'm glad you brought that up because I want to ask just an open-ended question to you guys from a provider standpoint. One thing Dr. Rogers mentioned was that pain is a signal, and he actually mentioned the dangers of not feeling pain. So where, how do you coach patients from a standpoint of you can call it mindfulness, you can call it, cognitive, behavioral change, all that stuff that you were talking about, Amber. But when do you listen to the pain versus when do you try to redirect your attention? Because I find that to be fascinating. And, I've always been of the mindset, well, I can redirect my attention and thus control it. But then with the way Dr. Rogers was speaking about pain as a signal, I think you almost have to have a balance. Does any one of you guys have a follow up to that or thoughts on that? Because I find that topic super fascinating.
It depends on the nature of pain, because when it's acute abdominal pain, and I went through this last year, and I just kept saying I had a virus, and I kept laying on the couch, and after about 8 hours, my husband's like, I've never seen you like this. I think we should do something. I'm like, no, I'm good. I go overnight. Long story short, it was my appendix, and that was my body. I kept thinking this is going to get better, and then obviously I kept deteriorating. So I think that knowing those signals, and especially if it's an acute type situation, and knowing when to listen is important.
Andy, I think you had something to say.
I think that's a hard question. Pain is a signal, but then you think about, oh yeah, push through the pain. Like exercising can be painful. It could be perceived as this hurts, running or lifting weights. But I think trying to teach patients, because that's a hard question, Ben. That's a really hard question. You want to teach them to push through. I mean, exercising is going to be painful. Waking up may be painful to you, but pain, an acute type of pain, what Amber is saying, is different than the pains of life. Does that make sense? Is that stupid to think of? Push through the pain to freaking work out. But if your bicep is torn off, don't lift a weight. Does that make sense?
Mm-hmm. I think Amber brings up a good point. Anytime it's different than normal, like her husband said, I'm not used to seeing you like this. Anything interfering with like just activities of daily living, if normally you're taking the stairs and you're not, or if, family members or people around you are, well, this is different. I'm not used to seeing this. Because sometimes when you're in it, you don't really see things clearly. And so you really have to listen to those around you. And if they're noticing things are different than what normally have been. So I think that's important.
That's a great point, Kara. Like
anything,
just noticing outside the box.
Mm-hmm.
Anything that's outside the normal, and that's what Amber was saying with her husband noticing that. I think that's it, and
also too things that persist. My husband, he was diagnosed with Crohn's 3 years ago, but he had been having colonoscopy since he was in 8th grade, and they just couldn't figure out what's wrong. Like, why is this kid always saying his stomach hurts? Why does he have these GI? When there's your body, there's other ways of determining things, even if it's not a clear-cut answer. Listen to the other signals that are coming too, because most of the time there's going to be a causation.
Yeah, Fran, what's your thoughts on that? Because I want to get your input here, because I just feel like pain is such a, even with the question I asked, it's borderline a bad question, because there's so many different variables, but yet it's one of the two reasons in general why people come and see you guys and see providers in general. So what's your thoughts on just acute pain versus this is a pain that we can get over?
Well, just, I guess, asking all the appropriate questions and trying to find out the nature of the pain, and if you can come up with a reason for it. Like you said, like if you've been working out like crazy and gosh, you can't lift your arm, well, guess what? Your muscles are over fatigued and inflamed, and yes, you can't move your arm. But if you haven't done anything and you're laying in bed at night and you've just got this radiating pain down your arm, even when you're not moving, it lets you think, hey, that's probably nerve pain, right? If you're not even moving and you're in pain, it's the different qualities of pain can kind of help you determine where it's coming from. And then of course the entire history of what have you been doing, like with your stomach pain, had you been around a lot of people who had the stomach virus, and maybe you're just in pain because you have that? Are you the only one in the family who's buckled over in pain and throwing up? And, just looking at the whole picture and trying to come to a rational conclusion about where to start.
I think that's exactly right, and we're gonna wrap up here, guys, because we're running out of time. Any final thoughts on chronic pain? It is such a huge topic, and like we've said before, it's, being tired and being in pain are two of the main reasons people come and see us and people come and see doctors in general. Any final thoughts before we wrap up here, guys?
For those patients who are in chronic pain, I think, and they've dealt with it for so long, I was encouraged by some of the lists that Dr. Rogers, your only option is not opioid medication. Lots of people think it is, and I'm not saying there's not a place for that, but if you can, even alternating an NSAID with Tylenol, or the different modalities like physical therapy and stretching and non-steroidal Toradol injections, things like that. I think that's encouraging to those people who have lived with pain for so long that there are options to care for that.
Andy, you wanted to mention something, I believe?
Yeah, a couple things. One, he mentions an inflammatory diet. I do think that often we miss an opportunity of what we put in our mouths. Like, food is energy, and you are a machine, and that is your fuel for the machine. Think about what you're putting into the machine. If you put dirt into a computer or into your car, it's probably not going to run. You need premium gasoline. It's going to run better. And I feel like I'm reading a book called The Doritos Effect. Oh my God, it will make you not want to eat anything ever again, because processed foods have all these additives to get you to eat another chip. It's insane. So I do feel like I do think our diet can be cleaned up. He mentioned that. Another thing he didn't mention, which I'm surprised, is low-dose naltrexone, because he's a big proponent of LDN, and I'm sure we've done a ton of things on that. And Fran and I talked this morning. Fran and I just had a meeting at the mines this morning. So, but we talked.
If I could have just been a fly on the wall there, that would have been just a wealth of insight.
But she's reading a book on low-dose naltrexone, which is a non-opioid. It's not a narcotic. It's actually an antagonist, and using it in low doses has been used for a variety of treatments. One of which I learned this morning was thyroid disorder, but also too with weight loss, and with chronic pain management too. You can't be on a pain medication while doing low-dose naltrexone, but there's a lot of other things that we can do. And knowing too, if you learn anything, pain is subjective. Opioids mask the pain. And I think start digging, seeing what's the root cause.
I'm really, really glad you said that thing about the low-dose naltrexone. We were going over our podcast stats, and the most listened to podcast episode of Dictations is the one on low-dose naltrexone. For the listeners out there, I will link that episode in the show notes of this podcast. Guys, we've run out of time. Such a big topic, and I'm sure it's one that we will talk a lot more about. I appreciate y'all taking the time today. To the listeners out there, thank you for listening. If you have not subscribed to our YouTube channel or to Performance Medicine Weekly, I think we call it Performance Weekly. I apologize. Performance Weekly. Go to our website, performancemedicine.net, or Performance Medicine Audio on all the social channels. Guys, that's it. I love you all. Thank you.
Bye. Thank you.